Welcome back to the deep dive. You know, it's amazing how such tiny things like bacteria can cause such big problems in the body.
Right. It really is. And when those bacteria decide to become resistant to our antibiotics, that's when things get really tricky.
For sure. That's why we're diving deep into the IDSA guidelines today.
Specifically focusing on how doctors are tackling these antibiotic-resistant infections right here in the U.S.
Exactly. So get ready for some serious medical terminology, but don't worry.
We'll break it down and make it as clear as possible.
Our mission is to equip you with the core knowledge of how doctors approach these challenging situations. You actually sent in some excerpts from the IDSA guidelines, right?
Yeah, I did.
Okay, perfect. Let's jump right in. The first section covers general management recommendations.
And right off the bat, we come across the term CUTI,
Which stands for?
complicated urinary tract infection.
Okay, CUTI. Now, for those who might not be familiar...
What sets a CUTI apart from a regular UTI?
Right, what makes it complicated?
Well, think of a simple UTI, like a quick visit to the doctor, whereas a CTI is more like an extended stay. It just means there are additional factors that make it trickier to treat.
Nice.
Things like structural issues in the urinary tract, underlying health conditions, or even just the fact that it's happening in a man.
Oh, that makes sense. UTIs in men are definitely less common.
Exactly. And because of that added complexity, the guidelines recommend treating CUTIs similarly to pyelonephritis.
Which is?
A kidney infection. It's a much more serious situation.
Wow, okay. So these CUTIs are not to be taken lightly.
Definitely not. And one of the key themes throughout these guidelines is the emphasis on personalized treatment.
Personalized medicine is all the rage these days. But what does that actually look like in the context of these infections?
It basically means tailoring the treatment approach to each patient's individual circumstances.
Like their medical history, other conditions they might have, and the specific bacteria causing the infection.
Exactly. And another crucial concept is empiric therapy. Now, have you ever gone to the doctor with a suspected infection and they started you on antibiotics before getting your lab results back?
Oh yeah, definitely. They want to get ahead of the game, right?
Exactly. That initial treatment, based on the doctor's educated guess about the likely culprit, is called empiric therapy.
So it's like a calculated risk.
Exactly. It's all about starting treatment promptly while waiting for those lab results to confirm the exact bug and its sensitivities to specific antibiotics.
Makes sense. You don't want to wait around and let the infection get worse while you're waiting for those results.
Right. And speaking of treatment, the guidelines also address how long treatment should last and when it's safe to switch from IV antibiotics to oral medications.
Now, you'd think that if the bacteria are resistant, you'd need a longer course of treatment, right?
Logically, yes, but the guidelines actually state that the treatment duration shouldn't differ based on resistance.
Oh, really? That's interesting.
Yeah. Unless, of course, the initial empiric therapy was incorrect. If the doctor started you on the wrong antibiotic, they might need to adjust the treatment length.
Makes sense. You got to hit those bacteria with the right weapon, right?
Exactly. But here's a fascinating twist. For simple cystitis, even if the initial antibiotic choice wasn't spot on, extending treatment might not actually be necessary.
So those uncomplicated bladder infections can often clear up even if the initial antibiotic wasn't a perfect match.
That seems to be the case. Now, before we move on, let's take a quick look at Table 1 in the guidelines.
This table outlines recommended dosages for various antibiotics, right?
Yep. We won't bore you with the whole thing, but let's highlight a few key players that will be relevant later on.
Okay, sounds good. Give me the highlights.
First up, we have amikacin. This one has a unique single-dose option for uncomplicated cystitis.
Interesting. So one and done.
Exactly. Remember that. It'll be important later. Next, we have ciprofloxacin. This one has different dosages depending on whether it's a simple or complicated UTI.
So the dose adjusts based on the severity of the infection.
Exactly. And finally, there's fosfomycin, specifically for uncomplicated cystitis.
Got it. Amikacin, single dose for uncomplicated cystitis, ciprofloxacin with varying doses, and fosfomycin for uncomplicated cases.
You got it. It's like familiarizing ourselves with the tools in our antibiotic toolbox before we tackle those tougher cases.
Love that analogy. Speaking of tougher cases, are you ready for our first multiple choice question?
Hit me with it.
Okay, listen carefully. This one's all about those tricky bacteria called extended-spectrum lactamase-producing Enterobacterales.
Or ESBL-E for short.
Right, ESBL-E. Now, these bacteria are kind of like master escape artists.
They've evolved this clever way to break down many common antibiotics, making them completely useless.
And the most common type of ESBL we see in the U.S. is called
CTXM.
CTXM. Got it. But here's the tricky part. Routine testing for ESBL isn't very common, so doctors often rely on clues to suspect its presence.
Like what?
Well, if a bacteria is resistant to ceftriaxone, a type of cephalosporin antibiotic, that's a big red flag.
Ah, so it's like detective work. Clinicians are using their knowledge and experience to piece together the clues and figure out what they're dealing with.
Exactly. And the usual suspects for ESBL-E are E. coli, Klebsiella pneumonia, and Proteus mirabilis.
Names you might recognize from those pesky UTIs.
For sure. Okay, ready for the question?
I'm all ears.
All right, here it is. What single IV dose antibiotic is an alternative treatment for uncomplicated ESBL-E cystitis? Take a moment to think about it.
This is where those details from Table 1 come in handy.
You got it. All right, time's up. The answer is amikacin. Remember we talked about that single-dose option earlier?
Ah, I see where this is going.
It works because amikacin is eliminated from the body very quickly, making it perfect for a quick strike against those ESBL-producing bacteria in a simple cystitis case.
It's like a surgical strike. Get in, do the job, and get out.
Exactly. Now, let's talk about another single-dose option, fosfomycin.
This one's specifically for uncomplicated cystitis, but there's a catch.
Oh, what's the catch?
It only works against E. coli infections.
So knowing exactly which bacteria is causing the infection is crucial here.
Absolutely. And surprisingly, most labs don't routinely test for fosfomycin susceptibility.
But the good news is,
Resistance to fosfomycin is still relatively rare in the U.S.
so it's generally a safe bet for those uncomplicated E. coli UTIs.
It seems so, but there was a recent study that found that fosfomycin didn't perform as well as nitrofurantoin, even when specifically targeting E. coli infections.
Oh, really? Yeah, that's interesting.
It's a reminder that even our go-to treatments might not always be the best, and ongoing research is essential to ensure we're using the most effective strategies.
Absolutely. So we've covered the basics of ESBL-E, but let's dig a bit deeper into the nuances of treatment.
Okay, sounds good. Where do you want to start?
Let's look at question 1.2 in the guidelines. This one focuses on those complicated UTIs where things get a bit trickier.
All right, let's dive in. This question brings up a really interesting possibility. It suggests that multiple doses of fosfomycin might be more effective for complicated UTIs, even though we don't have definitive proof yet.
So it's a bit of a medical mystery.
Exactly. More research is needed to confirm whether this is actually true.
Okay, I'll keep my eye out for any updates on that. Now, the guidelines also have a warning about using amoxicillin clavulinate for ESBL-E cystitis.
Yes. That's an important point to highlight. Even though lab tests might indicate that amoxicillin clavulinate works against these bacteria,
It's not recommended.
that's right, and there's a good reason for that.
Okay, I'm all ears. Spill the tea.
Studies have shown that amoxicillin clavulinate doesn't fully clear the bacteria from the vagina, which can lead to higher rates of recurrence.
Ugh, recurrent UTIs. Nobody wants to deal with that.
I know, right? It's not fun. And those findings come from a study, even though the dosages used in that study were actually lower than what's usually prescribed.
So it's possible that even at higher doses, amoxicillin clavulinate might still have this issue.
That's a possibility. It's just something to keep in mind.
Okay, good to know. Now let's switch gears and talk about aminoglycosides and plasmamycin.
These are good backup options when other antibiotics aren't cutting it.
So they're like the heavy hitters in our antibiotic arsenal.
Exactly. But we have to use them carefully.
Why is that?
They can potentially damage the kidneys, a condition called nephrotoxicity.
Ah, that's no good. We want to avoid causing any additional harm while we're trying to treat the infection.
Absolutely. Speaking of plasmamycin, there's been a trial that showed some changes in creatinine levels, which is a marker of kidney function.
So there's that potential for kidney damage.
But the good news is that plasmamycin seems to be more effective against these resistant bacteria compared to other aminoglycosides.
So it's a bit of a trade-off.
It's about weighing the risks and benefits and choosing the best option for each individual patient.
Makes sense. So we've covered some of the key players in the fight against ESBL-E, but let's step things up a notch. Are you ready for another multiple choice question?
Bring it on.
This one revolves around ESBL-E bloodstream infections, which are Serious business. These infections can spread throughout the body, making them potentially life-threatening.
Definitely not something to mess around with.
Right. And the guidelines recommend carbapenem therapy as the top choice for these infections. And there's good reason for that. A big clinical trial provided some solid evidence. So here's the question. What were the 30-day mortality rates for patients receiving piperacillin tazobactam versus meropenem for ESBL bloodstream infections? We're looking for the rounded percentages from the original study. Think carefully.
This question really highlights the importance of choosing the right antibiotic, especially when dealing with these severe infections.
Absolutely. Okay, time's up. The answer is 12% mortality for patients receiving piperacillin tazobactam and only 4% mortality for those receiving meropenem. That's a huge difference.
It really shows how powerful the right antibiotic can be in these life or death situations.
And even though the trial later reanalyzed the data with some adjustments, the trend remained consistent. Meropenem still came out on top.
So it's not just a fluke. Meropenem really is a strong contender for treating these severe infections.
So the takeaway here. First, carbapenems are the clear winners when it comes to fighting those serious ESBL infections. And second, those oral antibiotics we talked about earlier, like nitrofurantoin, they're off the table for bloodstream infections. We need the big guns here.
We're not messing around, and this finding about the effectiveness of carbapenems is actually extrapolated to other infection types, even if those specific scenarios haven't been directly studied. That's how we build these guidelines, by using the best available evidence and applying it broadly.
That makes sense. Now let's talk about piperacillin tazobactam, which popped up in that last question. Question 1.4 in the guidelines has some practical advice on its use.
Okay, what does it say?
If a patient was treated with piperacillin tazobactam for uncomplicated cystitis, and it worked, no need to change the treatment.
So if it ain't broke, don't fix it.
Exactly. But for those more complicated UTIs, like pyelonephritis or CUTIs,
For guidelines recommend choosing a different antibiotic, right?
you got it. Options like TMP-SMX, ciprofloxacins, levofloxacin, or those powerful carbapenems we talked about earlier.
So basically, while piperacillin tazobactam might still work in those more complicated cases, there are other options that are generally preferred.
And there's another interesting point here for infections outside the urinary tract. Piperacillin tazobactam is a no-go, even if lab tests show it's susceptible.
Interesting. So even if the bacteria seem to be vulnerable to it in the lab, there are other factors to consider.
Exactly. The location and severity of the infection matter, and each scenario requires a tailored approach.
Makes sense. Now, what about cefepime? Where does that fit into all of this?
Cefepime. That one's a bit tricky. Question 1.5 in the guidelines explains why.
Lay it on me. What's the deal with cefepime?
Well, cefepime faces a double whammy.
Oh, how so?
First, it can be broken down by those ESBL enzymes we talked about. And second, tests for cefipime's effectiveness can be unreliable.
So it's a bit of a gamble.
Exactly. There was even a study where cefepime failed to treat an ESBL-producing E. coli infection, even though the MICs, those minimum inhibitory concentrations that measure bacterial susceptibility, looked okay on paper.
It's a reminder that we can't rely solely on lab results. We need to consider the bigger picture.
Absolutely. So what's the takeaway message regarding cefepime?
Avoid using it for those serious ESBL-E infections and stick with those more reliable carbapenems.
Okay, good advice. Now let's venture into the world of cefamycins.
Another class of antibiotics.
Yep. Question 1.6 in the guidelines tells us that cefamycins should be able to resist those pesky ESBL enzymes. But the data is a bit messy.
How so?
Well, observational studies have given us conflicting results. Some studies show no difference in outcomes between cefamycins and other options.
So some are saying they work and some are saying they don't.
Exactly. And some studies even suggest that cefamycins might actually lead to worse outcomes.
Oh, wow. That's a red flag.
Right. And the largest study on this topic found that the 30-day mortality rate was significantly higher for patients treated with cefamycins compared to other options.
So until we have more research to clear things up, it's best to avoid using cefamycins for ESBL-E infections.
Agreed. We need more data before we can confidently recommend them.
Absolutely. Now, we've explored some of the more established antibiotics, but what about those new kids on the block? The newer beta-lactam antibiotics like ceftazidime, avibactam, meropenem, viborbactam, and others.
Those are the heavy hitters, right?
Exactly. They're powerful weapons in our arsenal, and they do work against ESBL-E.
So what's the catch?
The guidelines strongly suggest saving these potent agents for the most difficult cases, especially those infections that are resistant to carbapenems.
So it's like saving the special ammo for the boss battle.
Precisely. We need to be strategic with our antibiotic use to ensure we have effective treatments available when those tougher infections arise.
Makes sense. Now, get ready for another multiple choice question.
I'm always up for a challenge. What's this one about?
This time, we're dealing with Antibiotics-producing Enterobacterales.
AmpC producers.
Yeah.
These guys are tricky because they have yet another way to resist antibiotics.
Right. They produce enzymes that can break down a different class of antibiotics, making treatment even more challenging.
So the question is, which bacteria are most likely to develop resistance during treatment, making us extra careful about which antibiotic we choose?
Think carefully. This one really highlights how dynamic bacterial resistance can be. It can emerge even as we're trying to fight the infection.
Okay, I'm thinking.
All right, time's up.
Yeah.
The culprits are E. cloac complex, K. aerugines, and C. frundii. These bacteria are notorious for starting out susceptible to an antibiotic.
And then bam, resistance develops, making things way more complicated.
It's like they're learning and adapting as the battle goes on. And that brings us to the end of part 1 of our deep dive.
We've covered a lot of ground, but there's much more to explore. We'll be back soon with part 2, where we'll continue unraveling the complexities of treating those pesky antibiotic-resistant infections. Stay tuned.
Looking forward to it.
All right, so we're picking up where we left off, talking about those AmpC-producing bacteria.
Yeah, those AmpC producers, they can be a real headache. Remember how we were saying they can actually develop resistance during treatment?
Right, right. It means we got to be extra careful when choosing our antibiotics.
Absolutely. So let's break down some key things to think about when tackling those AmpC infections, starting with cefepime.
Oh, yeah, cefepime. We touched on that one earlier when we were talking about ESBL-E. Kind of a double-edged sword, right?
In what way?
Well, cefepime is usually effective against AmpC, which is good, but it's less reliable against ESBL.
So it's like you have to choose your battles carefully.
Exactly. Cefepime might be tempting for AmpC, but you got to remember its weakness against ESBL, especially when you're dealing with bacteria that could be producing both types of enzymes.
Oh, wow. Yeah, that would make things even trickier.
Right. And to really drive this point home, there was a study from Taiwan.
Oh, tell me about it.
They were looking at ESBL-producing E. cloacae, and even when those MICs for cefepime looked okay, remember those measure how well an antibiotic stops bacterial growth? The mortality rate was 100%.
100%.
100%.
Wow, that's a scary thought. So it's like you can't always trust those MICs completely.
Exactly. Got to look at the whole picture, the specific resistance mechanisms and all that.
Makes you really appreciate those guidelines, right? Helping doctors make the best decisions.
Absolutely. They're like a roadmap. Okay, so moving on to Piperacillin-tazobactam.
Ah, yeah. What about that one?
Unfortunately, the data on how effective it is against AmpC producers is kind of murky.
Ugh, I hate when that happens. Makes things so confusing.
I know. There was this pilot trial, and it actually showed conflicting results. Some patients did well with Piperacillin-tazobactam, and some didn't. It's kind of a medical mystery at this point.
So for now, what's the best course of action?
The guidelines say for those AmpC producers, especially if there are any concerns about resistance to Piperacillin-tazobactam, just lean toward the carbapenems, just to be safe.
Better safe than sorry, right? Especially with these kinds of infections.
Right. And speaking of tricky situations, now we're entering the realm of Carbapenem-resistant Enterobacterales.
CRE. Oh boy, that sounds serious.
It is serious. Carbapenem-resistant means they're resistant to carbapenems, which are some of our most powerful antibiotics.
So what happens when even those don't work? It seems like a dead end.
It's definitely a big concern, but there's a glimmer of hope in question 3.1.
What does it say?
It points out that some Enterobacterales, even though they're called carbapenem-resistant, they might still be susceptible to some carbapenems. Like, they might be resistant to ertapenem, but still vulnerable to meropenem or imipenem.
Wait, so it's not a one-size-fits-all resistant label?
Nope. It's all about the nuances. That's why comprehensive susceptibility testing is so important.
So even within that resistant category, there might still be options.
Exactly. It gives doctors more tools to work with.
Okay, that's good to know. So let's zoom in on a specific type of CRE, KPC-producing Enterobacterales.
KPC.
What is that?
Well, KPC stands for Klebsiella pneumonia carbapenemis.
Okay, I'm already lost.
It's basically a specific enzyme that some bacteria produce to break down carbapenemins.
Oh, so it's like they have this weapon that disarms our antibiotics.
Exactly. But the good news is that question 3.2 outlines the preferred treatments for KPC-producing infections, and there's some good news.
Tell me more. I need some good news.
These newer antibiotics have actually shown better results than older treatments, so that's a positive step.
So it's like the cavalry coming in to save the day. What are these new wonder drugs?
We've got meropenem-vaborbactam, ceftazidime-avibactam, and imipenem-cilastatin-relebactam.
Wow, those are some serious names.
They're designed to specifically overcome those resistance mechanisms of KPC-producing bacteria.
So any favorites among the experts?
Well, the panel seems to lean towards meropenem-vaborbactam.
Why is that?
Based on how well patients do, and because it's less likely to lead to even more resistance.
Smart. It's like choosing the weapon that'll win the battle and prevent future wars.
Exactly. But the battle never really ends, does it? Now we're talking about NDM and other metallo-lactamase producers, or MBL producers for short.
Another mouthful. Break that down for me.
Okay, so NDM stands for New Delhi metallo-lactamase.
Why New Delhi?
It was first discovered in a patient from there, hence the name.
Ah, okay. So what makes these NDM producers so tough?
Well, they're even more resistant than those KPC producers we were just talking about. Question 3.3 really highlights this whole escalating arms race between bacteria and antibiotics.
Like a constant back and forth, isn't it? They develop resistance, we create new antibiotics, they figure out a way around those, and so on.
It's a sobering thought, really. Right now, there's no single FDA-approved drug that works perfectly against these MBL-producing bacteria.
So are we basically out of options?
Not entirely. The preferred treatments for NDM and other MBL producers are either ceftazidime, avibactam plus aztreonam, or just cefiderocol.
Hang on, remind me what aztreonam is again.
It's another type of antibiotic that works against those gram-negative bacteria.
Right, okay. So why is that combination so good against NDM producers?
Well, those metallo-lactamases, the MBLs, they can break down most antibiotics, penicillins, cephalosporins, even carbapenems. But aztreonam, they can't touch it.
So it's like the perfect weapon. Problem solved, right?
Not so fast. Those NDM-producing bacteria, they often have other enzymes up their sleeve, like those ESBLs and AmpCs we talked about earlier.
Right, and those can break down aztreonam.
Exactly. So that's where avibactam comes in. It can inhibit those ESBLs and AmpCs, basically protecting aztreonam so it can do its thing.
So it's like a tag team match. Avibactam is playing defense, so aztreonam can score the winning point.
Perfect analogy. And there's actually been some observational studies showing good results with this combo, especially compared to those colistin-based regimens.
Evidence-based medicine for the win. Now, on to another type of resistant Enterobacterales, OXA48-like producing Enterobacterales. What's special about these guys?
They're kind of fascinating because they're resistant to carbapenems, but often susceptible to other types of antibiotics.
Really? That doesn't seem to make sense. You'd think if they were resistant to carbapenems, they'd be resistant to everything.
It's not always that black and white. Bacteria have all sorts of ways to become resistant, and it's not always a resistant to everything situation.
Okay, so what are the preferred treatments for OXA48-like producers?
Question 3.4 lists them out, and you might recognize some familiar names. Ceftazidime avibactam, meropenem-vaborbactam, and imipenem-cilastatin-relebactam.
It's like the Avengers of antibiotics assembling.
Right, but the panel seems to prefer cefiderocol as an alternative for OXA48-like producers.
Why is that?
There's less clinical data on it, and they want to reserve it for treating even more resistant infections, like those caused by MBL-producing bacteria.
It's all about strategic planning, right? Making sure we have the right tools for the toughest battles.
Exactly. And now, let's take a step back and think about the big picture consequences of antibiotic resistance. Question 3.5 points out a really concerning fact.
What's that?
Using those newer lactam antibiotics against CRE, it can actually increase the likelihood of future resistance.
Oh, no. It's like a never-ending cycle. We fight resistance with new antibiotics, and it just leads to more resistance.
It's a constant arms race, and bacteria are amazingly adaptable. The more we use these powerful antibiotics, the more pressure we put on them to evolve.
It feels like we're always one step behind. So how do we break this cycle?
Well, we've got to use antibiotics wisely. Only when they're really needed, avoid unnecessary prescriptions, and make sure people finish their entire course of treatment.
Yeah, we hear that all the time, right? But what about specifics? Are there any specific recommendations in these guidelines for dealing with this resistance problem?
There are. Take KPC-producing bacteria as an example. Studies have shown that when you use those newer lactams against them, it can lead to changes in their genes. Specifically, the black KC gene, which is responsible for making that KPC enzyme.
So they're basically evolving to become even more resistant.
Yep. But here's the crazy part. Some of those changes can actually make them susceptible to carbapenems again.
Wait, what? So they become resistant, and then some become susceptible again. It's like they're playing tricks on us.
It just goes to show how complex bacterial resistance is. It's always changing, always evolving.
So practically speaking, what does this mean for doctors?
The guidelines recommend repeating susceptibility testing, the AST testing, whenever a patient who's had CRE in the past gets sick again.
So you can't just assume the bacteria will be resistant to the same things they were before.
Exactly. And if a patient was recently treated with ceftazidime-avibactam, the guidelines suggest considering a different neolactam for their next infection.
So it's like rotating crops to prevent soil depletion. We're rotating antibiotics to prevent resistance.
Perfect analogy. Now let's talk about combination therapy.
Okay, that's when you use multiple antibiotics at the same time.
Yeah.
Right?
And a lot of people think that's always better, but question 3.6 challenges that assumption.
So more isn't always better.
Sometimes not. There are actually a few reasons why.
Like what?
Well, first of all, more antibiotics means a higher risk of side effects.
Makes sense. More drugs, more chances of something going wrong.
Right. And sometimes antibiotics can interfere with each other. One drug might actually reduce the effectiveness of another.
Oh, wow. So they're working against each other instead of together.
Exactly. And then there's the issue of driving multi-drug resistance. That's when bacteria become resistant to multiple antibiotics at the same time.
So it's like we're accidentally training them to become superbugs?
Yeah, kind of. It's a delicate balance, and we have to be careful about using too many antibiotics at once.
Okay, I'm starting to see the downsides. Are there any specific examples in the guidelines?
There is. They mention a study where adding a second drug to ceftazidime-avibactam didn't improve outcomes for patients with KPC-producing infections. Sometimes one well-chosen antibiotic is better than a whole bunch of them.
Less is more. Okay, that makes sense. Now let's meet another tough opponent. Difficult to treat Pseudomonas aeruginosa, or DTRP aeruginosa for short.
This one's notorious for being resistant to lots of antibiotics. It's a real challenge to treat, especially in hospitals.
So what are our options against this one?
Question 4.5 talks about the preferred antibiotics for DTRP aeruginosa, and you might see some familiar faces.
Oh, like what?
The recommended drugs are actually the same ones we use for those tough CRE cases. Ceftolozane tazobactam, ceftazidime-avibactam, and imipenem-cilastatin-relebactam.
Wow, so those are the heavy hitters for both CRE and DTRP aeruginosa.
They are. It just shows how serious these infections are.
It really makes you realize how important it is to stay ahead of this resistance curve, right?
Absolutely. We need to keep developing new antibiotics and new strategies.
So are those our only options for DTRP aeruginosa?
Isofenterol is mentioned as an alternative, but it has some drawbacks.
Like what?
Well, you need higher doses for P. aeruginosa compared to other bacteria, and studies have had mixed results.
So it's not a guaranteed win.
It's a reminder that even our newer antibiotics have limitations.
True. Okay, what about MBL-producing P. aeruginosa? Are they even tougher to treat?
Unfortunately, yes. Question 4.6 paints a pretty grim picture, actually. Limited treatment options.
So what are our weapons of choice for this one?
Polymyxins, either colistin or polymyxin B, and aminoglycosides.
Okay, break that down for me. What are the nuances?
With polymyxins, polymyxin B is usually preferred unless it's a UTI.
Why is that?
Colistin is actually more potent in the urinary tract. It gets converted to its active form there.
So it's like sending in a specialist.
Exactly. And with aminoglycosides, they're only effective if the bacteria is susceptible to them.
So testing is super important here.
Absolutely. You got to know what you're dealing with before you start treatment.
Okay, makes sense. Now let's switch gears again. Carbapenem-resistant Acinetobacter baumannii, also known as CRAB.
CRAB. It's a big problem, especially in hospitals, and it's super tough to treat.
So how do we even begin to tackle this one?
Question 5.1 has some general guidance. The main recommendation is to use an antibiotic that contains sulbactam.
Sulbactam, what's so special about that?
It has this unique activity against sulbab.
So it's like our secret weapon.
You could say that. The preferred combo is sulbactam-durlobactam plus either imipenem-cilastatin or meropenem.
And what's the evidence for this combo?
Well, there was a clinical trial that showed it actually led to lower mortality and better outcomes compared to colistin plus imipenem-cilastatin, which used to be the standard treatment. So this is a really promising development.
That's great. But what if sulbactam-durlobactam isn't available?
The guidelines recommend high-dose ampicillin-sulbactam with a total daily dose of 9 grams of sulbactam plus at least one other agent. That's our backup plan.
So we've got options.
We do. Now, let's dig a little deeper into why that carbapenem is added to sulbactam-durlobactam for SRAB.
Okay, I'm curious about that. Why is that combo so important?
Well, question 5.2 addresses this, and it might seem a bit counterintuitive at first.
How so?
The carbapenem, even though it wouldn't work by itself against crab.
So it's useless on its own.
Pretty much. But it actually helps the sulbactam-durlobactam work better. It's the synergistic effect.
Interesting. So they're like partners in crime.
Exactly. One theory is that the carbapenem helps weaken the bacteria's outer membrane, letting the sulbactam-durlobactam get inside and do its thing.
Ah, so it's like the carbapenem punches a hole in the wall and then sulbactam-durlobactam comes in and cleans up.
Perfect. And there's a study that backs this up, showing better outcomes when the carbapenem is included.
Always good to have evidence. Now, what about ampicillin-sulbactam?
That's a decent alternative when sulbactam-durlobactam isn't around. But it has to be high dose and combined with something else.
Okay, so no solo missions for ampicillin-sulbactam.
Nope. It needs backup. And there's a bunch of research that suggests it has potential. Lab studies, animal models, and even clinical trials, though not all of those reach statistical significance.
So it's a reasonable option when you need it.
Exactly. Now, let's talk about combination therapy for CFRAB again, using multiple antibiotics.
Right. I thought that was always the way to go with resistant bacteria.
That seems logical, but question 5.4 says the evidence for combination therapy with CFRAB is actually pretty limited.
So it's not as straightforward as we thought?
Nope.
Nope.
It's more complicated than that. And there have been trials that looked at different combinations with some disappointing results.
Like what?
Well, a lot of them just didn't show any benefit compared to just using one antibiotic.
So sometimes one well-chosen antibiotic is better than a whole cocktail of drugs.
That's what the research suggests. There's a good example of this with colistin and rifampin.
Tell me more.
This trial looked at C. crab infections, and they gave some patients just colistin and others colistin plus rifampin. Guess what? Adding rifampin didn't change the mortality rate at all. Both groups had a 43% mortality rate.
So the rifampin was basically doing nothing.
Pretty much. And there was another similar trial looking at C. rab pneumonia. And again, adding rifampin to colistin didn't make a difference.
So 2 strikes against that combo.
Right. And there was even a third study, this one with colistin-resistant baumannii. They didn't specify if it was Carbapenem-resistant or not. And again, colistin alone and colistin plus rifampin had similar outcomes.
So 3 strikes, you're out. No benefit from adding rifampin.
Exactly. Now, there was another trial that compared colistin alone to colistin plus fosfomycin.
Okay, did that one work any better?
It seemed like adding fosfomycin might offer a slight advantage. The mortality rate was lower in the combination group.
So maybe fosfomycin is a good partner for colistin.
There's a catch, though. Intravenous fosfomycin isn't available in the U.S., so those findings don't really apply here.
Oh, right. Even if something works well somewhere else, it might not be an option for us.
Exactly. Now, there were 2 other big trials that really hammered home the point that combination therapy isn't always the answer for SAP.
What did those trials look at?
Both of them compared colistin alone to colistin plus meropenem, and neither showed any benefit from adding the meropenem.
So another strike against combination therapy.
Yep. The first trial included patients with C. crab bacteremia, pneumonia, or UTIs.
And the results.
They used a high dose of meropenem and even gave it as a prolonged infusion, but the mortality rate was almost identical between the colistin-only group and the colistin plus meropenem group.
So even with all that, the meropenem didn't really make a difference.
Right. And then the second trial focused on SAP ventilator-associated pneumonia, and they used a similar dosing strategy for the meropenem. But again, no significant difference in mortality.
So another swing and a miss for combination therapy. Are there any cases where it does work for SAP?
There was one trial that showed a potential benefit. They compared colistin alone, colistin plus meropenem, and high-dose ampicillin-sulbactam plus colistin.
And the winner is?
The ampicillin-sulbactam plus colistin combo showed a significant survival advantage compared to colistin alone.
So combination therapy wins in this case.
We have to be careful about interpreting those results, though. That trial was done in a place where colistin resistance is really common, and the colistin-only group had a really high mortality rate, like 82%.
Oh, wow. So it's possible that colistin was just a really weak opponent in that trial, making the combination therapy look better than it actually is?
Exactly. It's not always as straightforward as it seems.
Okay, so what's the bottom line on combination therapy for SHREEP?
The evidence isn't very strong for its routine use. While some combos might be promising, we need more research to really confirm their benefits and figure out the best regimens.
Got it. No jumping to conclusions, and no assuming that what works in one place will work everywhere.
Exactly.
Okay, so where do we go from here?
Well, question 5.5 talks about polymyxins for treating CRAB.
Polymyxins, right? Those are kind of a last resort, aren't they, for those really tough infections?
They are. And they recommend using polymyxin B combined with at least one other antibiotic.
Why polymyxin B specifically?
It's better absorbed and distributed in the body, so it can really reach those infection sites.
So it's kind of like the preferred polymyxin.
Generally, yes. But there's an interesting exception.
Oh, tell me more.
For CRAB in the urinary tract, colistin is actually preferred.
Why is that?
It gets converted to its active form in the urinary tract, so it's more powerful there.
Makes sense. It's like sending in the specialist for that specific job.
Exactly. It shows how the best treatment can really vary depending on where the infection is.
Right. Now with those MICs, those minimum inhibitory concentrations, are those reliable for polymyxins? Those are the ones that measure how well an antibiotic stops bacteria from growing, right?
They can be tricky with polymyxins. They don't always give us the full picture. If the MIC is higher than 2 micrograms per milliliter, chances are it's not going to be very effective.
So another reminder that those lab tests aren't perfect?
They're a guide, but we always have to consider the context.
Okay, good to know. What about those tetracyclines? I know those are used for a bunch of different things.
Yeah, like acne and respiratory infections, you name it. But question 5.6 looks at whether they're any good for CRB.
Indeed. What's the verdict?
It's mixed. They looked at minocycline and tigecycline.
Right.
And using tigecycline alone, especially at low doses, it can actually be dangerous. There have been studies linking it to higher mortality rates.
So solo tigecycline is a no-go.
Especially at those lower doses. But there is some evidence that higher doses might be comparable to other options.
So it's all about the dosage.
Well, and even at higher doses, tigecycline should always be combined with something else for SRAB.
Got it. Teamwork. What about minocycline? Any warnings there?
Minocycline is considered safer than tigecycline, but again, they recommend high doses and combining it with other antibiotics for SRAB.
Okay, so same rules apply. High doses, teamwork.
Exactly. And just a heads up, tetracyclines can cause nausea. That's a common side effect.
No, yeah, the dreaded nausea. I've definitely experienced that before.
It's usually manageable, but something to be aware of.
All right. Now, what about cefiderocol? We touched on that one really.
Yeah, cefiderocol, it looked really promising in the lab, but when they took it to clinical trials, mixed results.
So it didn't quite live up to the hype.
Not entirely. There are some concerns about its effectiveness, particularly for pneumonia and bloodstream infections.
What kind of concerns?
Well, one study showed that mortality was actually higher in the cefiderocol group compared to those who got other treatments, mostly polymyxin-based regimens.
So it performed worse than the older treatments.
In that specific study, yes. And another trial found that it was no better than meropenem for Crab pneumonia.
And meropenem isn't even that great for SICO, right?
Exactly. So it seems like we need to be careful with cefiderocol and wait for more research to really understand its place in treating crab.
It's a constant learning process.
Yeah.
All right. Are you ready for one last multiple choice question?
Hit me with it.
Okay, here we go. We've talked about how adding carbapenems to other drugs for SRAB hasn't shown a clear benefit. So why is that? What makes carbapenems often ineffective against a SRAB?
This is a good one. It really makes you think about all those bacterial resistance mechanisms we've been talking about.
All right, time's up. The answer is OXA carbapenesis.
That's it. They're enzymes that specifically break down carbapenems, making them useless.
So even if you include a carbapenem in a combination treatment, it might not be doing much at all.
Exactly. It's all about understanding those details, the mechanisms behind the resistance.
Okay, good to know. What about rifamycins for SRAB?
Question 5.9 says they're not recommended.
Why not?
They did trials combining efimpan with colistin, and there was just no benefit.
No benefit at all.
Nope. And rifamycins have potential side effects, so the risks just don't outweigh any potential benefits.
Okay, so steer clear of those. Now, for our final bacterial foe, Stenotrophomonas, maltophilia.
Another tough one. Multi-drug resistant, just like SRAB. Really hard to treat.
So what are our options here?
Question 6.1 acknowledges the difficulty. They say there's no gold standard treatment.
So no magic bullet. What do they recommend then?
Two main approaches. The first is combination therapy, using at least 2 drugs that are active against it.
Why 2?
Because one alone just isn't likely to cut it. They list the preferred agents too. Cefiderocol, minocycline, TMP-SMX, and levofloxacin, in that order.
Okay, so teamwork is key here.
Absolutely. And the second approach is ceftazidime avibactam plus astrionem,
Wait, isn't that the combo for NDM-producing bacteria?
It is, but it can also be used for S. maltophilia infections, though the data for this one is a bit more limited.
So it's the possibility, but we need more research to be sure.
Exactly. Now remember, so fit to recall, question 6.2 talks about how it might work for S. maltophilia. It's really effective in the lab.
Almost 100% susceptibility to that.
But there's a chance you might need higher doses for S. maltophilia compared to other bacteria.
So dosage is important here.
It is, and there's always that worry about resistance developing.
So it's a promising option,
Yeah.
but with some caveats.
Exactly. Now, let's talk about minocycline again. Question 6.4 says it's the only tetracycline with those CLSI breakpoints. Remember, those help us determine susceptibility.
Right.
But they recently changed them, so what used to be considered susceptible might actually be resistant now.
Oh, wow. So we really need to stay up to date on those guidelines.
Absolutely. And those other tetracyclines, eravacycline and omadacycline, those are not recommended.
Okay, so minocycline is the way to go if you're going with a tetracycline.
Right. Now, TMP-SMX. This one's interesting. Question 6.5 highlights a real head scratcher.
What's that?
It works great in the lab against S. maltophilia, but several studies have shown that it might not actually be killing the bacteria, even at those concentrations that seem to work in the lab.
So it's like a trickster. It looks like it's working, but it's not?
Exactly. And some studies have even said it might be worse than levofloxacin, but then others have said it's similar to other drugs. It's confusing.
So what's the bottom line with TMP-SMX?
Use it as part of combination therapy, but we definitely need more research to figure out what's really going on.
Okay, sounds like a plan.
Yeah.
What about those fluoroquinolones, specifically levofloxacin?
Question 6.6 says they do have some activity against S. maltophilia, but they're not that great on their own.
Another one for the teamwork category.
Exactly. They've done studies showing they don't always stop bacterial growth, and even in animal models, high doses didn't seem to do the trick.
So not the most reliable on their own.
But there was a meta-analysis. You know, those studies that combined data from multiple studies that hinted that fluoroquinolones might be slightly better than TMP-SMX, but only for infections outside the bloodstream.
So there might be some specific scenarios where they're a good option.
Right. But overall, stick to using levofloxacin as part of a combination.
Okay, last one. Ceftazidime. Any role for that against S. maltophilia?
Question 6.7 says it's simple. Ceftazidime is just not effective.
Why not?
S. maltophilia is intrinsically resistant to it. It just doesn't work.
So we can cross that one off the list?
Exactly. And that, my friend, is the end of our deep dive into the IDSA guidelines for managing antibiotic-resistant bacteria.
Wow, we've covered a lot of information.
Yeah.
Complicated UTIs, CRE, crab, S. maltophilia. It's been quite a journey.
It's a complex field, always evolving, but hopefully this deep dive has given you a better grasp of the challenges and the latest thinking on how to overcome them.
I know I've learned a ton. Thanks for walking us through it all.
My pleasure. Always happy to share the knowledge. And remember, this is just a snapshot. Things are constantly changing in this field, so stay curious, stay informed, and keep asking those questions.
Great advice. And that brings us to the end of this episode of The Deep Dive. Be sure to like, subscribe, and share this episode with your friends, family, and anyone who might find it helpful. We'll be back next time with another deep dive into the world of fascinating facts and cutting-edge knowledge.